Prostatitis is one of the most common urologic problems for men. It can be classified into 4 categories. Category 1 is acute bacterial prostatitis. Category 2 is chronic bacterial prostatitis. Category 3A and B is chronic non-bacterial prostatitis or chronic pelvic pain syndrome. And Category 4 is asymptomatic inflammatory prostatitis. First, let's talk about acute bacterial prostatitis. The risk factors include bladder outlet obstruction, such as benign prostatic hyperplasia or stricture disease, lower urinary tract procedures like prostate biopsy or urethral catheterization, phimosis, immunosuppression due to HIV or diabetes, urinary tract infection, history of sexual transmitted disease, and indwelling urethral catheters. The infection can be caused by several organisms. The most common one is Escherichia coli. Other organisms include Pseudomonas aeruginosa, Serratia species, Klebsiella species, and Enterobacter aerogenes. Gram-positive organisms include Enterococci. Patients with a history of HIV infection should be checked for atypical pathogens. Next is diagnosis. In the history, systemic symptoms include fever, chills, malaise, arthralgia, and myalgia. Irritative or obstructive voiding symptoms like dysuria, urgency, and frequency. Acute urinary retention in 20% due to bladder neck spasm, and perineal or rectal pain or lower back pain. In physical examination, avoid vigorous prostatic exam or massage in a patient with suspected acute bacterial prostatitis. This may cause bacteremia and sepsis. If possible, avoid urethral instrumentation as well. Vital signs could indicate about signs of sepsis, including fever, tachycardia, and hypotension. An abdominal examination may reveal a palpable bladder or abdominal fullness, suggesting acute urinary retention. The digital rectal examination performed cautionally, and the prostate gland may be extremely tender, warm, boggy, and swollen. Diagnostic test and interpretation. The lab tests include complete blood count that will show leukocytosis with left shift, urinalysis with proteinuria, pyuria, and hematuria, and also positive leukocyte esterase and nitrite. Urine and blood culture, particularly for immunosuppressed patients. And prostate-specific antigen, but it has little clinical value in the clinical setting, and it will be elevated in the majority of cases, so it should be repeated after 1 to 2 months following treatment. Imaging is not routinely required, but may be indicated if fever persists despite appropriate treatment to evaluate for prostatic abscesses. This could include CT scan, ultrasound, or MRI. General measures in treatment. First of all, indication for admission and intravenous antibiotics is high fever, significant leukocytosis, and sepsis. Next is analgesis in antipyretics. Also, you can use stool softeners and bladder drainage if there is evidence of urinary retention. A urethral catheter should be placed cautionally. If you have any difficulty or if the patient is too uncomfortable, percutaneous suprapubic tube should be placed. If there is no clinical response within 48 hours despite appropriate treatment, consider a prostatic abscess. In medication, first-line treatment include use antibiotics that can easily reach the prostate tissue. Fluoroquinolones like levofloxacin 250 to 750 mg daily or ciprofloxacin 250 to 750 mg twice daily. Other options include ampicillin with gentamicin or ceftriaxone 1 to 2 grams daily. If fever reduces within 24 to 48 hours, switch to oral antibiotics. You can also adjust antibiotics choice based on urine or blood culture results. Switch to oral antibiotics after acute symptoms have resolved. And full antibiotic treatment should last 2 to 4 weeks. Second-line treatment includes oral antibiotics as the first choice for patients without severe symptoms, such as fluoroquinolones for 10 days or trimethoprim sulfamethoxalone 160 or 180 mg every 12 hours. Surgery may be required if prostatic abscess develops. It usually needs to be drained, which can be done through needle aspiration using ultrasound guide and local anesthetic. Also, we can perform transurethral drainage or open drainage. But methods involving cutting or removal may lead to higher chances of sepsis. Open drainage is used if less invasive methods don't work, or if the abscess has spread beyond the prostate. Now let's talk about chronic bacterial prostatitis. Chronic bacterial prostatitis includes symptoms of prostatitis with positive urine culture and no signs of systemic infection. The risk factors include inadequately treated episodes of acute bacterial prostatitis, older men with benign prostatic hyperplasia or bladder outlet obstruction, urethral strictures, urethral catheterization, possibly reduces sexual activity with resulting prostatic congestion. In terms of pathophysiology, with progressive benign prostatic enlargement, obstruction causes reflux into the prostatic ducts. Obstructive turbulent and high-pressure voiding, combined with intraprostatic ducts reflux, leads to acute intraductal inflammation. This can progress to chronic intraductal inflammation, and bacteria are present in inflamed ducts in protected bacterial aggregates or bacterial biofilms, as increased incidence of prostatic calculi may serve as a nidus of infection. And pH of prostatic fluid may increase from a normal of 6.5 to 8.0 with infection. Common pathogens include Escherichia coli, Enterococcus faecalis, Klebsiella pneumonia, Pseudomonas aeruginosa, and Proteus saprophyticus. Other pathogens include Staphylococcus epidermatitis, Staphylococcus saprophyticus, Corynebacterium, and Ureaplasma ureolyticum, Chlamydia trachomatis, Candida, Mycobacterium hominis, and tuberculosis. Diagnosis involves first history. Symptoms such as dysarthria, urgency, nocturia, and weak stream. Perineal, pineal, scrotal, suprapubic or groin pain, and pain with or after ejaculation. Erectile dysfunction, decreased libido, prior UTIs or STDs, unprotected intercourse or new partners, or urethral catheterization or other lower genitourinary surgery. In physical examination of the genitalia may reveal vague widespread pelvic discomfort. Perineal tenderness may be present. Digital rectal examination may reveal a minimally tender or bulky prostate. And prostatic calculi may be palpable. Diagnostic tests begins with laboratory tests that include urine analysis and culture. Routine urine culture may be negative. A positive culture may be obtained as part of measured STEMI 4-glass test. Pyuria and bacteriuria may be present. PCA may be elevated in setting of prostate infection and should not be obtained until the infection clears. Imaging has low yield and is performed only to exclude the presence of other more definable and treatable causes of patient symptoms. Transrectal ultrasound performed in patients with pain on ejaculation and may reveal enlargement of the prostate or seminal vesicle. Prostatic calculi may be also visualized. In the setting of possible acute bacterial prostatitis or prostatic abscess, prostatic massage should not be performed. In diagnostic procedures, the Mizhi STEMI 4-glass test considered gold standard for the diagnosis of chronic bacterial prostatitis and may involve isolated cultures of different portions of the lower urinary tract. To perform this test, first of all, make sure that the patient has a full bladder. Next, you need to clean the gland thoroughly with antimicrobial solution. Retract the foreskin as necessary. Next, you need to void 10 ml into the sterile container VB1. This represents urethral flora sample. After voiding 100 ml, collect 10 ml midstream urine in another sterile container VB2. This represents bladder flora sample. Next, you need to perform prostatic massage to collect EPS from the urethra. Submit for culture and examine on glass slide under 40. and this represents prostate flora. After that, you need to collect the next voided 10 ml in a sterile container, and this represents a combination of prostate and bladder flora. Normal results include negative urethral prostatic and bladder cultures. VB1, VB2, EPS, and VB3 are negative. Normal prostatic secretion show no evidence of excess white blood cells, they less than 10 white blood cells per high-power field. Positive results include if EPS or VB3 colony are 10 higher than VB1 or VB2, that bacterial prostatitis is present. If all cultures are positive, then bacterial cystitis is likely present, and the test should be repeated after 5 days of antibiotics. A modified measure-STEMI test, two-glass test, and that is considered more convenient and practical. So what you need to do? After cleansing the glands, obtain 10 ml of midstream urine for culture. That represents bladder flora. And this should also be dripped for white cells. Next, perform prostate massage and obtain 10 ml of urine for culture and microscopic exam. And that represents prostate and bladder flora. If white cells are present, they may represent bacterial prostatitis or NIH type 3A. If post-massage colony count are 10 higher than pre-massage sample, bacterial prostatitis is present. If both cultures have similar counts, cystitis is present. The general measures in treatment: antibiotics course normally extended for 6 to 8 weeks and sometimes longer with refractory infections. The goal is to eradicate the needles of infection in the prostate. The patient should avoid alcohol, spicy foods, perineal pressure for extended times, like sitting or bicycle riding, and acidic beverages. In medication, first line look like that. Current sensitivity patterns are showing increased resistance to quinolones, TMX, sulfa, and ampicillin. In choosing antibiotic coverage prior culture sensitivity reports, no local resistant patterns based on your hospital antibiograms. But fluoroquinolones still preferred. And no difference in bacterial eradication between levofloxacin and ciprofloxacin. Also, prostatic fluid concentration of levofloxacin is higher than ciprofloxacin. Ciprofloxacin has daily dosing and may have better prostatic penetration. Ciprofloxacin 500 mg per os beat for 4 to 6 weeks. Levofloxacin 500 mg per day for at least 6 to 8 weeks. Trimethoprim 60 mg sulfamethoxalone 80 mg beat for at least 6 to 8 weeks. Tetracycline derivatives, for example doxycycline, only if chlamydia or mycoplasma suspected. In second line, anti-inflammatories like ibuprofen for symptoms. Alpha blockers, for example doxazine, tamsulazine, alfuzazine, and thilodazine, may help with LUTS. TURP can be considered in selected cases of refractory prostatitis with infected calculi and/or obstruction. In additional therapies, frequent ejaculation in patients with enlarged symptomatically congestion glands, dietary modification, and most heat with sitz baths or heating baths for symptomatic relief. Next is chronic non-bacterial or inflammatory and non-inflammatory prostatitis. The risk factors include urethral catheterization, inadequately treated urinary tract infection, pelvic trauma, urethral strictures, and psychological stress or depression. In terms of pathophysiology, the etiology is unclear in 90%, while the remaining can be attributed to bacterial origin. The exact cause is unknown, but is considered multifactorial, involving a combination of factors. Current theories include non-bacterial colonization, atypical bacterial infection, voiding dysfunction causing intraprostatic urinary reflux and elevated intraprostatic pressure, pelvic floor muscle dysfunction, endocrine, neuropathic, and autoimmune theories. For diagnosis, in history, determine duration of symptoms. for at least 3 months duration. Pain in the suprapubic region, lower back, penis, testes and or scrotum. Painful ejaculation, one of the most discriminatory symptoms associated with CP, CPP-A3, and a strong predictor of quality of life and severity of pain. Sexual dysfunction, pelvic floor muscle spasm, irritative or obstructive voiding symptoms like urgency, frequency, hesitancy, poor interrupted flow. History should also cover neurologic disease, hematologic, cardiovascular, and infection diseases. In physical examination, careful exam of genitalia, groin, perineum, coccyx, external anal sphincter, and internal pelvic floor and side walls. A digital rectal examination should be performed only after preprostatic massage urine has been collected. In diagnostic test, urinalysis and urine culture, 4-glass test, considered to be gold standard in diagnosis. The 2-glass test may reveal difficulties with interpretation of bacterial localization studies, as asymptomatic individuals often harbor uropathogens. Pelvic imaging with ultrasound, CT or MRI is optional, but can be used to rule out other causes of pelvic pain if clinically indicated. In general measures, this condition often requires multimodal therapy, as it is considered multifactorial. Treatment should also be targeted to the etiologic mechanism using the U-point system. The choice of agents in the first or second line setting is practitioner dependent, with no specific agent approved specifically for this condition. The alpha blockers, multiple randomized placebo-controlled trials, have demonstrated a duration at least 3 months or longer may be needed before assessment can be made of treatment, failure or success. The side effects of alpha blockers include hypotension, dizziness, fatigue, and retrograde ejaculation. And usually uses alfazazine 10 mg bead for 12 weeks and contraindicated with moderate hepatic insufficiency or with cytochrome P450-3A4 inhibitors. Doxycycline 1 to 4 mg daily for 12 weeks. Escalate dose until symptoms relief obtained. Tamsulosin 0.4 mg daily for 12 weeks. Enteroxazine 1 to 5 mg daily. Escalate dose until symptoms relief obtained. 5-alpha reductase inhibitors usually uses finasteride 5 mg daily or dutasteride 0.5 mg daily. Anti-inflammatory agents like rofecoxib 25 to 50 mg daily. The symptom relief at higher doses, but not recommended because of cardiovascular risk. Also oral prednisolone 100 mg tide. Gabapentinoids like pregabalin 150 to 600 mg daily. And finally muscle relaxants like baclofen or diazepam. Other procedures include transurethral microwave thermotherapy. Category 4 is asymptomatic inflammatory prostatitis. This is a diagnostic made when white blood cells are found incidentally on pathology specimen collected for rising prostate-specific antigen or abnormal digital rectal examination. As patients are asymptomatic and have no bacterial infection, no treatment is required.